This is a 75-plus-year-old gentleman with diabetes, hypertension, Parkinsonism, you name it, the works he's got. And he's also got end-stage glaucoma. Yeah, he is already having a cystic bleb from a mitomycin seed trab, which was performed almost a decade ago, I suppose, and now come with a very, very dense cataract for phaco. Now, there are a lot of problems in these cases. One is mainly the bleb that these eyes can be so hypotenuse, and you can see how I'm struggling to even make the incision. So I've somehow managed that incision. I then do my side ports and look at the side port. The cornea is just folding on me, and this you will see will give me a problem later on in the surgery. I then stain the capsule. I am expressing out. Do not overinflate the chamber, but as with all glaucoma, chronic glaucoma cases, the zonules are not that great, and you can see it here as well. So I am having a bit of a problem doing the rhexis. However, with a little patience, I am able to manage the rhexis. It's probably a 5.5 mm rhexis, which will do well. And now comes the next part. Remember, don't overinflate the eye. You don't want this bleb to suddenly rupture or some untoward incident like that happen. And watch the nucleus. I'm hydrodissecting, not too good. So I go to another area, and you can see the nucleus coming forward, obviously coming forward. So that's a very good hydrodissection. Decompress, and I'm trying to rotate, and I just cannot rotate. And this can happen even though you know you have a good hydrodissection. There could still be capsulocortical attachments, or the zonules could be loose, whatever. So, but without proper rotation, I do not want to start this case. So I have again hydrodissected, and then with a little bit of mechanical rotation, I'm able to rotate it a few degrees, and that will do. So you know that it is separated, the nucleus is separated. I will do this several times, but not too aggressively. I'm not going to do it 360 degrees round. I'm very scared of exerting too much torque on the zonules. I already know they're probably weak. There's no point in being aggressive here. So once I think there's enough nuclear rotation, put in some chondroitin sulfate and sodium hyaluronate, going in with a very, very sharp chopper, and my phaco power is around 80%. Vacuum, I've dropped it to 350. Normally I go at 400. My flow rate is 35. My bottle height is only around 90 centimeters. I've dropped it down from 100 centimeters. We need to have little low flow in these cases. And look at that side port, how it is leaking. And this is what I told you, that this side port incision is going to give me trouble. However, in a way, probably a blessing in disguise. I do need this. I don't want to overinflate this chamber with such a cystic bleb. That bleb looks very scary. So I do get chops. They are still attached in the center. Probably need to do a lot of lateral separation, but I am not doing that much, as I do not know the integrity of this capsular bag. Just removing all the bits and pieces of epinucleus which is occluding my view. And basically I am not getting a full chop because frankly speaking I am not laterally separating that much. I am very reserved in my lateral separation. So I would like to get at least 6 pieces, if not more, in a case like this. And that one piece has almost come out. Decide better to eat it away so as to make some space for me. And you can see, even with eating of that piece, I'm still having problems with nuclear rotation. So I target another piece, and you can see the epinucleus there. I decide better put in some sodium hyaluronate and then rotate the rest of the nucleus for better accessibility. And I am doing it very carefully. I am not exerting, I am not pushing against the fornices of the bag. Please watch how I am rotating that nucleus. And one by one I am targeting these pieces. Yes, it is just slightly, probably the epinucleus at least is slightly above the iris plane. It's because the pupil is also shutting down on me. I am trying to bring this into a more accessible area. Again I am targeting, I take 2 dialers and look how I am rotating the nucleus. Very carefully. The epinucleus is partially out of the bag, and that is why I am having so much difficulty. So I want to target those attachments in the center, but it is slightly risky because I do not know if the posterior capsule is bang next to it. So although the temptation is there, do not do it. Take out all these fibers that are first blocking your view. Trying to use that dialer to bring those fibers. Yes, I brought it down, and once I brought it down, automatically the apex tilts up a bit and I can engage it. And there, that's done. Once you get that apex, it's far easy to go ahead and remove the rest of those nuclear pieces. And since this patient has got so many comorbidities, I can't even put in he is on an anesthetic standby, and my anesthetist has refused for me to allow you to even put in some intraocular adrenaline. So I take out some of the cortex. First inject this. This is a safer procedure probably. Put in your IOL first into the bag, and then try to aspirate the cortex over the IOL. This is very safe. It's a little bit tiresome, but it is safe. And you can see there is a lot of cortex. Should never be fooled thinking there's no cortex. Always keep a mental picture of the areas where you haven't cleaned the cortex, and there will be cortex there. So very slowly targeting, trying to get in a big piece into my port and then strip it off. And with that, I conclude my surgery. Thank you so much for watching.